Well, thank you all for joining us today. We continue this day-long conversation about what the rest of Texas can learn from El Paso with a focus on healthcare. El Paso is a community in which people are learning more about the health conditions facing communities of color and the challenges in access to healthcare. And what can other border communities learn from El Paso? Considering that question and others are Dr. Ogechika Alozie, CEO of Sunset ID Care. Dr. Alozie is an infectious disease specialist serving patients in El Paso and is also focused on how health information technology can improve care. Dr. Glenn Fennelly is Assistant Vice President for Global Health for Texas Tech University Health Science Center's Paul L. Foster School of Medicine. He also serves as Board President of Doctors of the World. Aida Ponce is the Chief Outreach and Wellness Officer at Project Vida, an organization focused on meeting the El Paso community's health, education, housing, and wellness needs. And our moderator today is Dr. Jessica Chacon, Assistant Professor of Immunology and Microbiology at Texas Tech University Health Science Center, El Paso. Dr. Chacon.
All right, thank you very, very much for that warm welcome. Before we start, I just want to give a round of applause to our expert panelists. So I wanted to start there. If you join me in giving a round of applause. Okay, thank you. So let's get to it. So, Dr. Alozie, can you tell us a little bit about what specific health conditions are prevalent within our underserved border communities? And how do they differ from those in other aspects or other areas?
Yeah, absolutely. So first of all, thanks for the crowd for coming. It's always a pleasure. Thanks for Texas Tribune for having me, and thank you for moderating. I don't think there's any surprises in this conversation, right? If you're in healthcare, in and around healthcare, or you have loved ones who are above the age of 50, and I say that now self-deprecatingly because I'm above the age of 50, so I'm a little bit worried when I talk about above 50, but it's diabetes, it's hypertension, it's obesity, right? If you take majority of the healthcare conditions that affect our community and any community across America, and really the world, as you get the Americanization of the global economy, right? The McDonald'sization of the global economy, those are the things that affect us. I think, however, and we can talk about this a little bit more, when you look at a primarily Hispanic community, there are some things around the biomechanics, and you can talk to this about the immunology, about how their kidneys function, right? About cardiovascular disease and coronary plaques and atherosclerosis. There's a lot of things that also do seem in that genetic combination to have a higher effect in that demographic than other demographics. And so if you were to say, what is the number one thing that you can do in any community, specifically ours, a border community, I really think it would be education and obesity, right? You change those and you actually start to blunt the curve around hypertension, around diabetes, around kidney disease, around heart disease. And that actually starts to make an effect. And as we saw during COVID in the 2020 to 21 period and even beyond, majority of the people that had either morbidity, right, bad outcomes or mortality around COVID were specifically people that were either obese, age, or had cardiovascular and renal issues, right? So you start to work on those and you start to see actual effects and how you can make a community healthier. And I'm sure we'll talk about ways to get to that healthier eventually.
Thank you so much. I'll pass it on to you, Dr. Fennelly. Anything to add in respective to the specific populations looking at adults and children?
Yes, again, I want to thank everybody, Texas Tribune. It's great to see some familiar faces in the audience, people with whom I work each and every day and have the privilege of serving the healthcare needs of El Paso. So I see this from the pediatric perspective. I'm a pediatrician, pediatric infectious diseases. So it begins early. In El Paso, we have a teen pregnancy rate that's 60 to 80% higher than the rest of the country. We have a child poverty rate, 34% or higher, twice the national rate. Uninsured children, 12 to 14%. So that's one piece of it, and that very much factors into the social determinants. And the challenge with obesity, diabetes, hypertension begins before adolescence even. So 1 in 5 of our 10 to 17-year-olds are obese. Again, tie in with COVID. When my colleagues in Europe heard about us going nuts immunizing children against COVID, they're asking, what's that about? We saw cases here beginning, again, before 10 years of age, risk factor being obesity. So that's a major factor. And when you tie in with that poverty, it's hard for families each and every day to make good food choices. Another important statistic in terms of some of the so-called social determinants of health is that we only have 70 spaces for our child daycare for every 100 children. So, I want to give a brief shout out to Children at Risk that got Prop 2 passed, which is going to give El Paso the option of expanding, if you will, real estate tax relief to help support and grow and preserve that demand. Briefly, in terms of infectious diseases, you see stuff here that you ain't going to see anywhere else. An infant, is it coccidiomycosis or is it TB meningitis? You have to make that difficult choice. The border is a literal barrier to healthcare access. If a child is sick there with not too unusual cases like Rocky Mountain spotted fever, they're transmissible by ticks, they're going to make their way over to the border. We also serve a rural area. El Paso Children's is the only hospital for a 350-mile radius that has highly specialized pediatric care. If a child with invasive group A strep, a complication of the common strep throat, needs care, they're going to end up here. Unfortunately, we see a lot of delay because of the distance, because of maybe the local access within their own communities.
All right, thank you so much. Lastly, Ms. Aida Ponce, a powerhouse in community engagement, outreach, collaboration. What aspects can organizations do to address some of these health disparities seen along the border?
Well, a little bit about us. Project Vida Health Center, we have around 6 clinics in different communities, especially in the colonias, Montana Vista, Agua Dulce, Central area. And one of the biggest things that we do with the community is really looking for them. One of the biggest strategies that we use in our health center, we are one of the 3 FQACs in El Paso. The other 2 are San Vicente and La Fe, and we are one of the 3 here. And something that we use for years, I believe I can say for more than 20 years, we have been using the community health worker model, promotora model, and this is what we use in order to address the conditions of the community and start having these connections with them.
Okay, and going along those lines, can you tell us a little bit about what healthcare barriers our community members are facing in our community?
Híjola. Well, a lot of my Spanish. Okay, yes, a lot of barriers. Obviously, the first one is access to healthcare. Is the first one. We don't have the expansion of the Medicare. Is something that is very big, but also cultural. We see a lot of barriers around culturally with our community. We see every single day when our community care workers are outside, they face this intimidation for some of our community members to the medical system. Sometimes we need to take a lot of time to educate people, to let them know and talk to them and debrief with them about fears, about their way that they can address and approach the system. We take a lot of time to educate them and talking about what is important and mostly to be with them, to navigate them, to help them to navigate the system. Actually, one of our main role as a community health workers that we have is navigators. They take the hand, literally they take the hand of the client since the beginning when they see them in the health first, and they start talking and listen them. Mostly this is the biggest barriers is the intimidation, obviously access, sometimes priorities. The community has, at least the community that we as a FQAC we serve, is community that have 2-3 jobs. Sometimes they don't have time. And yes, they have issues in their health, in their family, in their mental, but they have the priorities. They need to work. And this is one of the biggest things that we see.
All right, thank you so much for that insightful answer. And I am very supportive of the promotora model, the community health workers serving as patient navigators. It's very instrumental to our healthcare, and I know that Texas Tech is also very supportive of promotoras as well. Dr. Fennelly, in addition to promotoras and community health workers, are there other alternative or additional innovations that have been used to break down that barrier to healthcare access?
So yeah, I can respond from the perspective of Texas Tech and how we try to get our students involved very early on with, if you will, learning about the realities and thinking of solutions. One is an introduction to the colonias. El Paso, as you may be aware, has the second largest colonia population in the entire state, the first being Hidalgo County. Very early on, the students go out there. They see, if you will, some of the barriers to just delivery. There's absence of addresses. They see the lack of potable water. Beyond that, there is a medical student-run health clinic that's supervised by two of our faculty, Dr. Blanca Garcia, Dr. Maureen Francis, and actually Dr. Maria Velanos also participate in that. In many ways, that's a lifeline for that community. Coming up, April 17th from the 21st, is the Days of Service at Texas Tech, where the entire Texas Tech community will be involved, and there's a list of about 26 organizations ranging from the Alzheimer's Society of West Texas to a, if you will, a Salvation Army thrift shop that the students, faculty, and others can be participate in that. Also, we have a program, a joint program between Doctors of the World, Texas Tech, and Annunciation House, where our students, faculty, and residents are providing first-line health care for the migrant and refugee community. So this is a model that we hope to build on, that's sort of filling a gap that we hope in time is filled by our county, UMC, et cetera, system to give the care that is necessary. If we don't provide it, there are downstream effects from it. So we see it as a way of averting emergency room visits, urgent care, saving all of us money in the long term while providing humanitarian care. So those are just a few examples.
All right, thank you. So what I'm hearing is that it takes a community, a collaborative effort to help our patients, especially along a border community. Dr. Allozy, can you tell us a little bit about how healthcare providers can better understand and address the cultural and linguistic needs of diverse communities?
I'm laughing not because it's not a great question. It's a great question. I'm laughing because as a non-Hispanic, originally non-American, I'm Nigerian by cultural and birth, it's always interesting to me, right? And so one thing I will say is that when I moved to El Paso, myself and my family, it was the closest cultural bond that we had had living in the United States to Nigeria. And that is a credit to our community and the drive that they have for family. Families first, families important, we're hard workers. All the things that you see on the plethora of news services that are out there that are ridiculous don't exist, right? And I bring a lot of friends into the community, either to work, live, or visit, and they're always amazed and they say, well, that's not what I saw on TV. Right, this is, wow, this is like a real city. I was like, yeah, I'm aware. But so I think one of the things about our community and about culture is that in as much as we have those competing priorities, in as much as we have the multiple challenges that are driven by socioeconomic factors and the border, the community as a whole wants to be healthy. Right? There are just challenges systemically that affect things. A lot of times when and this is to pivot to your direct question, what can my colleagues do, is be more amenable to be more open-minded. And unfortunately, the community and the culture of El Paso is a double-edged sword. It's a great thing in that patients treat you in a sense like a deity, but it's a bad thing because they treat you as a deity. I did majority of my training up in Minnesota, and I would have patients that would come in with a 40-page folder, and they would go through 62 questions in a 10-minute visit, right? And Dr. Google and this app and the other app told them all the things about how I'm a bad doctor and I haven't gotten to the 99th diagnosis for their 2 symptoms that I should have thought about. That doesn't happen in this community, right? And a lot of my colleagues, unfortunately, use that not to necessarily give culturally competent care, right? They're pushing the answers upon the patient instead of coming to a collaborative conversation. Now, don't get me wrong. In my space, if you have HIV, if you have hepatitis C, if you have a bloodborne infection, the answers to cure or to suppression are very few, right? But the pathway to get there is complicated by, do you have insurance? Do you have access to care? Do you have transportation? And a lot of times, again, because we're a healthcare shortage area and all of us are busy, right? My average colleague in Austin and San Antonio sees 20 to 40 patients in a hospital a day. My average census in the last 12 months has been 80 to 90 a day, right? Now, I supplement that by using nurse practitioners, and we're a partnership in a team, but it's a very different conversation when you're seeing 90 patients than when you're seeing 40, right? And so I think one of the things that my colleagues can do, and I think the medical school and the dental school and the nursing school very focused on this, and they do a great job, is reminding anybody that is a healthcare worker or healthcare aligned that it's not about you. It's about that patient in front of you every single day, every single visit, to ensure that you are answering their questions and they're getting what they need, not necessarily what you need.
All right, thank you. Dr. Fennelly, any perspective specifically coming from the pediatrician aspect?
Could you, repeat the core of the
Sure.
question?
I talked a lot.
It's okay.
So how can healthcare providers better understand and address the cultural and linguistic needs of diverse communities?
Right. So, I'll start with, if you will, sort of an evidence-based observation. When the healthcare workforce reflects the community it's serving, we have better outcomes, whether it's in Black maternal mortality, you name it. I remember an unfortunate incident when I was working in Newark, New Jersey, about 10 years ago, where we had a never event, kernicterus, hyperbilirubinemia in a newborn infant whose mother didn't understand the instructions that weren't in Spanish, they were in English at discharge. That would never happen here. We're a community that's 80% Hispanic. I'm so struck here by the bilingualism. I speak a bit of Spanish, but I'm constantly immersed on the wards in the hospital by people that are fluent, not just in the language, but in the cultural understanding, and I always aspire to learn. Our medical students here, 48% self-identify as Hispanic, so they're going to be the future of healthcare. Those that don't speak Spanish, we have a curriculum in medical Spanish that teaches impressive competency. I'm very impressed with the 3rd and 4th year clerks on the ward that didn't speak Spanish before, but they know when to step back and ask for a translator. So I'm really hopeful. And again, I need to echo what you say about the friendliness of this community. I'm a bit of an outsider too. I came from New York. I'm a Jersey boy, but I felt incredibly embraced here and welcomed, as did my wife, who's originally from Beijing.
All right, thank you so much. Ms. Ponce, can you tell us a little bit about how organizations are working with healthcare providers to address some of these disparities?
Well, in our organization, something that we have been doing for years now is working in care teams. The community care workers play the role as a care coordinators inside of the clinics. We have one care coordinator, or sometimes if budget allow us, 2 care coordinators in each clinic. And obviously they are not part of the medical team, but they are part of the care team. And medical providers, MAs, the whole team, behavioral health, community care workers, care coordinators, they are part of the medical team, and we believe that this model has been very helpful because we know that the medical providers, as you mentioned right now, they are so busy. You guys are so busy. One of the other barriers that we have in our organization, obviously, is capacity. Capacity, yes, because we have a lot of clients, a lot of services that people need, and doctors, they don't have a lot of time. They have a certain amount of time with a client, with a patient, and this is why to have a care coordinator in their team is very helpful. They have, we are inside of the clinic, and they have the ability, or also we have the ability to the electronic record to send the refer, and the care coordinator is the person who follow up the care of the patient. In this case, talking about conditions in our health center, the 3 main conditions that we see is hypertension, diabetes, and mental health. is the third. And also mental health, we have a very big number in between 12, 18 years because we are in the schools as well. And this is why it's something that we see. When they have this part of the care team is helpful, is also another very good strategy to connect with community because, again, sometimes our community, they are intimidated for the doctors. And sometimes they don't tell the truth. They don't tell the truth. We have a lot of stories. Talking about stories, I have a lot of stories. I don't have time, but I have a lot of stories in which they are with the patient, with the doctor. They close the door. They go with the care coordinators and they start to, no, I'm not going to take this medicine. No, I'm not going to. Why? Why do you tell the doctor that? No. Because people sometimes feel intimidated. This is why when we talk about diabetes education, for example, we have a class in which we empower them and we prepare them to not to have 200 questions, but at least to express and have trust with the provider. I don't know if I answered your question or I talk a
Absolutely.
lot.
Thank you so much. Just to follow up on that, how receptive is the community to attending those classes?
Well, a lot of stories as well. Let me show you statistics. Women, I have my numbers here. And women is the 60% of our population. No, 70%, 75%. Men is very low. And for us, it's a very big challenge. In terms of people come to the classes, well, usually our diabetes classes are packed or we have a good attendance, but the majority are women. We have been doing a lot of effort because we have more men go to the doctor but not join the classes. Now, when the doctor gives the referral, what do you guys believe they do? Any guess? They give the referral to their wives. They send their wives to our classes. They send their wives to our classes. But the people who have the condition is them. But they send their wives. And it's a barrier that we have been facing for years. Thank God, not anymore. We, little by little, we have been doing a lot of work. But another barrier is we don't have a community health workers men. We have all our community health workers are women. It's another barrier. However, right now, we have been doing a lot of efforts in terms of if the people came, we have a structure already. The providers are so important. If they take at least 1 minute more, 2 minutes to talk with the patient and tell and recommend to go to the classes, they do it. They listen them. And this is why we talk a lot with the providers. We are part of the providers meeting. We are part of everything inside of the clinic in order to work together to encourage clients, participants to come.
All right, thank you so much. The word community health worker keeps popping up in Promotoras de Salud. So before we continue with our panel, I just wanted to define what community health worker is for our audience and in person and online for those who may not have heard of it. So it is a person who lives in the community, who serves the community, who breaks down those borders between the community members and the healthcare providers. So traditionally they are women, but there are more men who can be trained as promotoras or also called community health workers. Okay, so can you tell us a little bit about the socioeconomic factors? Dr. Alozie, we're gonna start with you. What are some of the biggest socioeconomic factors that influence health outcomes and access to care in border communities?
I mean, when I used to be here and I would teach the students, right, I would always tell them, follow the money. Right, so you follow the money, you get to the answer on everything. And it may sound pliff, it may sound easy, but across border communities, if you account and adjust for socioeconomic status and income in a single or a dual household, that is the major variable in healthcare outcomes. Right, now age plays into it, but even at an age, you find that it confounds and it's really access to funds. Now, funds doesn't always have to be how much you make. As you already pointed to, we're at a disadvantage healthcare-wise in our community because we didn't have an expansion, right? And so in states that have seen that expansion, they've actually seen a reduction in morbidity and mortality in some of those poor demographics because their access, right? You can overcome lack of income if the system globally provides more access, right? And so that's why what UMC does and what the county does is so immense to our community. I know a lot of my colleagues often sort of bristle at the fact of more clinics and more things, but considering how health shortage deficient we are, I think it's critically important, right? The other thing you think about is our city is really interesting in how it's divided along I-10. Right, the below I-10 is essentially a healthcare desert, and so UMC and the FQHCs have done an amazing job of getting things in there. But again, it's funding, right? It's funding from the locality, it's funding from the state, it's funding from the federal government. I think there are ways around that, and your organization has done an amazing job at bringing in millions of dollars in funding that are extra governmental, and I think that has to be the key. At the end of the day, it's an old adage, but you got to think outside the box, right? You can't just worry about the line items that you get from each municipality. There are unique ways, and there are a host of organizations across the country, but money drives a lot of these things.
Okay, Dr. Fennelly, anything to add?
Right, so
Socioeconomic
I,
factors.
if you will, up top mentioned several of the high poverty rates among children, the high rates of uninsurance. So expansion of insurance would go a very long way, and it's, I think, something we all should support. We're probably would, in time, lead to lower property taxes in El Paso. We have a lot of unreimbursed medical care. We carry an enormous burden in terms of the ongoing refugee crisis and some of the healthcare needs there. But yeah, each and every day, some of the examples of what we see, there are, if you will, disparities every day in the decisions we make about when to discharge a child. There might be a child that has a bone infection or some other infection that needs IV antibiotics, but do we transition to oral antibiotics sooner because mom has 3 other children in tow and just can't keep on coming in? So even if it's an insured family, those disparities exist. And here we can't lose sight of the fact that we do serve a very broad rural community. So far afield that the families in most of southern New Mexico come here. It's much more convenient than going to UNM or the facilities up in Albuquerque. So that's another sort of challenge in terms of some of the differences in insurance. Few of them are, the Medicaid isn't accepted here. So there's some more examples.
All right, thank you so much. Ms. Ponce, so I want to switch topics a little bit, going along with what Dr. Fennelly was saying. And earlier we were talking about real estate. So I want to go into location, right? So we know that El Paso is in Texas, but it's on the other side of Texas from other major cities. And I used to live in Houston, so I drove the 12 hours many, many times. So it's very far from other major cities in Texas. But at the same time, how can we leverage the location that we're at? We are on the border of Texas, New Mexico, and Mexico. So how can we leverage that opportunity to improve healthcare along the border? So I'll start with Ms. Ponce, and then we'll go Dr. Fennelly and Dr. Losey.
Well, in the morning I was listening the first panelist, and it's a reality. We are fronterizos. It's totally different. The way that we live, the way that we think is totally different. When we have, for example, we have a teen pregnancy prevention federal grant, and this federal grant for teen pregnancy prevention, we are the only one that we have here in El Paso, but we need to have evidence-based curriculums, but obviously we need to do adaptations. Always, every single time when we have federal money, with which we have a lot of, not a lot, but several different grants, federal grants, we have to do adaptations. Why? Because of that, because the community is different. Because sometimes, I don't know, our community, for example, our clinic is very close to the bridge, and they walk every day. And the students, the people, they walk every day, and they come to us. And something that we do is we listen to the community, we acknowledge, and we don't judge them in the way that they do things. Sometimes they come to receive services with us, but something happens, and then change their mind, and they go to Juarez. to see the doctors. And then something happens and they come back. I don't know if you had been addressing that. And well, we understand that. We try, in this case, we don't judge them. We don't say nothing. We always, the doors are open, and we try to understand the way that they live and how they do the things that they do in this case.
Right, thank you. So open communication.
Totally.
Open doors, open communication. Okay, Dr. Fennelly?
Yeah, I mean, I see opportunity, if you will, in policy, the same way with business and manufacturing. We are one community that's divided by a border. I pointed out the examples of children that are critically ill that find a way to make their way across the border. We have seen families cross the border with children with an atrial septal defect that needs to be repaired, and a team of children's mobilizes to do that transcatheter, and then the child goes back. Could we formalize that? More broadly, could we help to elevate the practice or healthcare in Juarez? Many of our students are from Juarez. Stephanie Woods tells me that 1 in 10 of her nursing students likely commute from Juarez. So we're teaching and training the future generation. In terms of the Children's Hospital, again, to really support a really consistent, great children's hospital, we need a bigger catchment area. Could there be some sort of bilateral agreements? And then thinking really totally outside of the box, in Southern California, certain San Diegoans can cross the border and go into Tijuana to get their primary health care. Could we do that with dental care here or certain primary care?
And Dr. Alozzi, anything to add?
I'll make it short. I think that you've already spoken to this. I mean, I'll give my own story in terms of some of the primary work I do around HIV. So I treat patients or persons living with HIV that are here in El Paso, Juarez, Chihuahua, Las Cruces, as far as Albuquerque, Lubbock, they come down. And so I see them across the board. I will say this, as a sort of for-profit, non-profit hybrid organization, we probably get about 1/3 of our funding from non-governmental sources. And the driver in all of the grants that we write is our location. Right? It's our geolocation and the uniqueness because, for example, in Jersey or in DC or wherever it may be, they are not aware of that. They don't see that. And so I often tell people, it may be a disadvantage to be here, but flip it and make it an advantage to you, right? If you have grant writers, if you have people that are looking for funding, flip it on its head and make that an advantage and say, this is why you should give me this money, because you're giving $20 million to people in Chicago and New York and Atlanta that don't look anything like us, and you say you're giving it to Hispanics. If you want to really do it, come do it here. And so that would be my sort of word of advice.
All right, thank you so much. So I want to start with Dr. Fennelly on this one. I know you are a healthcare provider and also an educator. You're very instrumental in our medical students' education. So how can healthcare providers and educators engage with communities in border regions to co-create solutions that address unique health needs and challenges?
Right, so I appreciate the question. I'm very proud of our students. And you know, when we talk about the makeup of our students, they're not just coming from this region, from all over the world. We do have a high proportion that themselves were refugees and somehow became citizens of Texas so they could have the advantage of getting into medical school, and we're very proud to have them. They are all very service-driven. So I'll take the example again of this migrant and refugee clinic run out of Annunciation House sites. On any one Tuesday evening, you walk in there and you'll see 10 to 20 students. About 1/3 of them are pre-medical. They're helping with triage, they're helping with translations, they're helping with scribes, and they're also helping us come up with solutions for that population. Similarly, the medical student-run clinic in the colonias is serving a similar function. The day of service, that's once a year for a few days. I think some get a broader understanding there. But again, on our wards and our clinics, each and every day, they see the challenges and they're coming up with some exciting opportunities.
All right, thank you so much. Ms. Ponce, what role can organizations play to collaborate with healthcare providers and educators to address some of these needs?
Well, I believe the biggest role is to listen them and to provide a safety space to raise their voice. Something that we do a lot and is something that we have been doing through our director, Bill Schlesinger, 33 years ago, is to listen the community, to provide those spaces. When they start opening this health center in this area, they spent 2 years knocking doors of the community and listen the community. Really listen the community. I believe we as an organization, we have the responsibility to listen the community and not to do what we want to do or pursue our own agenda. But building trust with the community as organization, as medical providers, as everybody who works in the organization, building trust and listen them and through that start helping them to maybe looking for funding, depending on the necessities, responding of the necessities that the community have. Is something that in our health center, in our community center, is something that we have been doing until now. The initiatives that we have is through the response to the community's necessities. And we do that through putting our values to listen them, respect them in working.
Yes, absolutely. So building that trust with the community,
so
addressing
important.
healthcare literacy, really making sure you build those relationships so that way they're able to break down those barriers with healthcare professionals. Okay, Dr. Alozi, anything to add? Okay, I did like the question earlier about the magic wand. So I want to go ahead and start with Dr. Alozi. If you were to have a magic wand about how to address healthcare disparities along our border community, knowing where our location is, knowing the population that we serve, the major health disparities that we see, if you were to have a magic wand, what would be your wish and how would you try to implement?
So is this a one wish, or do I get like a genie 3 wishes?
We will go with 2 at the most.
This is a very frugal genie, I see. I think my number 1 would be Medicaid expansion. Right. I just think this is crazy. It makes no sense to be in the size of state that we're in that we don't have Medicaid expansion. It's nuts. It makes no sense. I'll get off the pulpit and move on to number 2. I think number 2 would be a combination of what my co-panelists have talked about, which is education, primarily of the mothers, because in Nigeria we have a saying, educate a man, you educate a man. Educate a woman, you educate the village. So I think that's important. And number 2.5, is because if you educate the mother, you educate the child. And if you educate the child, you may not be able to fix the 50-year-old, the 60-year-old, the 70-year-old, but you then create a generational change in behavior that's sustainable and can change that culture and that community. And so that's how I would approach it. Thank you.
So first, amen to the last point about educating the children. I'll echo the Medicaid expansion. To put that in context, in New Jersey, in Newark, New Jersey, one of the pockets of poverty in the Northeast, we had an uninsurable rate of less than 2%. That means children that had just recently arrived, that refugees hadn't signed up for Medicaid yet. Again, reminder here, we're at 12 to 13%. Medicaid expansion would improve that. And there's no question that access and that sort of support is going to improve health early in life. Second of all, I'm going to relate this to the border. And again, this is very much a part of where my attention is. A lot of the time, this entire community, Ruben Garcia, that you'll be hearing from a bit later, we have to come up with more humane immigration policies. And how can we sort of take off some of the burden that this community is carrying in terms of the crisis response?
Well, the first is the same, Medicaid expansion, but also I have another dream. I would like to, in our organization, really to have community health workers, more community health workers playing the roles as navigators, as care coordinators, and have this group that assigned for a provider, medical provider. For example, right now in one of our health centers, in the central area health centers, we have around 6 medical providers and only 1 community health worker for everybody. Only one navigator. If we can do a team that the providers can have a team to support, the navigator can support the patient in the access, maybe to do with My Texas Benefits, with everything that is around access, and the care coordinator around everything supporting around the care, the continuum of care, the education of the mother, the education of the kid. The education can be totally different because we can have more impact. Obviously, in order to do that, we need funding. And we are working in that. I have a grant writer, and she's there. And she always is, we're looking for that. But it's one of our issues. But it's a dream.
Thank you so much. So I want to thank the Texas Tribune for hosting us today. We have a wide range of audience members. So I'll start with Ms. Ponce. This is the last question before we open it up to audience members. So if you have somebody in the audience who asks our panel, what can I do to make a difference? What can I do today to help make a difference and to address health disparities in our border community? What would you say? And I'll start with Ms. Ponce.
Can you repeat the question again?
So if you had to talk about what somebody could do today to help to address some of these health disparities, what piece of advice would you give them?
I don't know. A lot. But to have advocacy, advocate for the people that need it. Really respect the people in where they are, wherever the situation is. Have low judgment and high compassion. And that's it. I believe is what we need to do, everybody.
And I appreciate that because not only have you told us the stories about how you've shown compassion and not shown judgment, but you've also shown it through your actions and with Project Vita. So I definitely appreciate that. Dr. Fennelly.
Yeah, so I mean, I see it in terms of advocacy again and perhaps giving. Advocacy, there are immediate opportunities with your council people. If the issue of childcare resonates with you or a loved one or a friend, please advocate for property tax relief. It's going to be done at the county level or at the city level. Beyond that, give of yourself, give your time. There are many opportunities, I think, through the Annunciation House shelters, giving an extra pair of shoes. I've seen firsthand how that goes a long way.
Thank you so much. All right, our last one, Dr. Alozzi.
For me, it's one word: vote.
Right.
Just vote.
All
Vote
right.
for people that actually care.
Thank you so much. So I want to open it up to the audience questions. Matt?
Wonderful. And just a reminder for those joining us online, you can ask your questions at texastribune.org/ask. We have about 15 minutes or so for Q&A. So those who are here in person and have a question, please feel free to come on up for first question.
Hi, my name is Malena. Thank you for everyone sharing this space with each other and myself and all the professionals. Some of the things that I've been thinking about, and I'm glad I'm asking in this section, is mental health and comorbidity and generational trauma. And so I think each of you provides so much to this region and this community in regards to those things. And so I'm just curious, in the next 5 years, our brain is held by our body, but I think we're not giving credit to how important our brain affects our body. And so I'm wondering, in this mental health and healthcare, what partnership are we creating to secure that they are a partnership and, one affects the other and one is important to the other, and access to many who don't have that in this area? It's for anyone.
If may I allow to answer, we are working a lot in the very low level, in the basic. We are educating the community, the people, about their own well-being, what it means for them to have their well-being healthy, what are the aspects in the life, and why it's important to have address those, and what is the impact that the situation that they live at home or in the workplaces or wherever they move affect their health. because we see that was a big disconnection as well between our clients, that when they have diabetes, for example, they believe that with medicine was the only thing that they needed. A lot of clients, a lot of patients believe that, and it's not. They need to do a lot of other aspects, and something that we are doing very, very intentional through years is educate the community about the power that they have of their own wellness and well-being, and understand a little bit more about that.
Thank you so much. Yes, and thank you for the question. I know that mental health and well-being can sometimes be a stigma in our community, and so thank you, Ms. Ponce, for addressing that.
Lisa Laguna, sorry. What did COVID teach us, and what things were implemented now, post-COVID, in helping these, address these disparities? Because we know we've heard from the previous panels, we are a unique community. Politics and funding takes a lot of precedence and a lot of influence on people. Such as drinking Clorox because somebody said to, or people are now not getting immunized, not getting the COVID vaccines. I have a lot of, we've seen in the hospitals babies that that the parents don't want to give them the hepatitis or any of those kind of vaccines. What has COVID kind of done to help, if anything, and programs that were initiated or to address these disparities?
Wow, where do I start? So I think interesting perspective as obviously an adult ID and as the former chief medical officer of Del Sol Medical Center during COVID. So when we had the tents outside, all the federal funding and the federal persons that came in. But to answer your question specifically, I think what it told us is that our healthcare system is broken. It's not like we didn't know that, but when you put a pressure test through a system, you find out where the cracks are, right? And what we found out is that our time to response kind of sucks. What we found out is that social media also kind of sucks and can affect the things you talked about around immunization. We're at some of the lowest immunization rates, this, both on the children's side and the adult side, that we've had in a generation because of misinformation. But don't want to be negative Nancy or Norman here. I think that it's also important to realize in our community, we were the #1 COVID immunization city in Texas, right? And that's not by luck. That's not by chance. It's because of the work that the county has done, Immunize El Paso has done, the health department has done. And when push came to shove in our community, sitting in some of those meetings with CEOs and CMOs and CNOs and people that would never have talked to each other or even responded to emails, they all came together, sat down and said, hey, what do we got to do for our community? Let's make it happen. Let's share resources. Let's share persons. And one plug, because you mentioned electronic medical records, and that's kind of my soft spot, is that we have an organization in our community called FIX, which is our Community Health Information Exchange. They did an immense job of connecting every single hospital and clinic in this city so that we knew who was in the hospital, when they were coming out, when they needed to go to a tent, and the medications they got, right? So again, it's one of those flip it on its head thing. Yes, we're on the border and there's some challenges, but when push came to shove, that culture of community is what drove us to improve and get better.
Thank you so much. Dr. Fenley, anything to
No, I guess what I was impressed with was how the community banded together, #1. Just as we arrived here, the New York Times had a front page digital interactive map showing the rates of mask compliance in the country. DeMarco was featured in that. My wife was behind some of that data in her former role. So that made us feel a lot safer about coming here in August of 2020. Also was how the community mobilized to vaccinate. The FBI had no plan for vaccinating their folks. So it was Rick Thine and all the volunteer vaccinators that said, hey, we have some extra vials. What can we do? I want to address briefly the piece of vaccine hesitancy. It's made it nutso. Some of the thinking, some of the ideas being promoted. And what's at risk here? Measles. You don't want that in your community. We saw that in the US in 89 to 90. We had several deaths, 5 in New York City. We had our wards filled with children too young to be immunized. Measles is a killer. So any friends, loved one, families, please encourage them to vaccinate their kids.
All right, thank you. And I can speak a little bit about what we did with our medical students during the COVID-19 pandemic. So our students were actually serving as educators for our community to talk a little bit about the COVID-19 virus, treatments, masks, why you should wear masks, preventative measures. So they were serving as educators, both in English and Spanish. And in addition, we partnered with Dean Woods here to work with the Medical Centers of America and the county to vaccinate 32,000 maquiladora workers in Juarez. And why? Because of what Ms. Ponce keeps saying, collaboration. Collaboration is key in order to help address some of these health disparities. Okay, Matt, do we have another question?
No, our program, we're going to close our panel conversation right now. If we can all give a hand to a moderator in our panel.